The topic is AI versus the clinician, but it does not say what does the AI mean. I'm going to use the term not artificial intelligence. I'm going to talk about augmented intelligence. So it's no longer about being artificial. It's about how do we augment our intelligence. And it's a pro point that we are going to use AI and we are going to augment our clinicians. And I'm thinking why I come back here, because last year also I debated on the same topic, and it's the same slide, and it shows the continued interest and the exponential growth. And I've been very privileged to be associated with the field. It shows in 2008 when we started working on neural networks, and how our work is symbolic of also the big exponential curve that you see elsewhere. And I know that even here at Cleveland Clinic, I'm very pleased to know that there are several AI initiatives. So the question is, how do we bring our clinicians to start using the AI? And the first reason why I think this is a curve we need to be using is because we now know that AI has been democratized. Each one of you here in the audience is using some form of the AI or not. We know that with the bringing in of the ChatGPT, our lives are easier to a great extent, because we can have the ChatGPT work on our emails. You can have them, the large language model, work on our patient notes, so that we can do higher caliber activity. So it is getting democratized. Nobody needs to be knowing lines of codes, and everybody can use it. And here is a major reason why we are here. We want to augment everyone. And in this picture, I think last time I showed a picture in which Dr. Rodriguez was augmented as Leonardo DiCaprio. And today I'm going to show him he's going to be a great fighter, and he's going to fight it out. He's going to have, he will have the ambition of keeping the pristine clinician intact, and I'm going to help him. I'm going to continue him fight out with us and be a brave model, or he could just be able to see himself in new ways, morphing himself along with the culture. And never ever seen before, he would have imagined he will be on the throne. He'll become a king, and he will rule the world.
How often do you think about the Roman Empire?
Daily.
He's daily thinking about capturing the Roman Empire and the empire around, and he can take all on this because of the new privilege that he will have of augmented intelligence that is going to elevate him up. And why do we need to elevate people like Dr. Rodriguez? Because he has been a gladiator. He's been fighting the battle. He's doing it all alone, and he has been fighting the Cleveland battle. He has been injured. He's bruised, and I can't see it anymore. I can't see him on the ground falling down. We need to do something. And that's what exactly we are going to do. So there is a big need that our community is facing. We are having burnouts. We are having global shortage. It's not about U.S. It's everywhere. We have a very big gap which is coming in. We soon will not have people being able to see patients. We'll have sonographer shortages. But not only there's a shortage, but we are seeing growing waiting times for imaging everywhere. Look around in our European countries. Look around in Australia. Look around in Canada. And now we can see it also in our own places where patients are waiting for imaging. The average wait times is continuing to grow, and this is a constant struggle. What do? How do we overcome this? Well, we use AI, and we already know that it has taken several steps in imaging. For example, in echocardiography, it can help with acquisition of high-quality data. It can do pre-processing. It can do feature extraction. and it can go on, and now there are decision supports that you can use that are coming in to augment your ability to even do the reports. So it is augmenting us in many ways. It has a tremendous impact on the workflows. It has gone on from not simple acquisition, but also being able to do individualized prediction. And finally, the point is that how much time we spend in taking care of patient in only trying to diagnose. We need to spend more time in therapy planning, and we don't have that time and the luxury. So we need to be able to relegate some of this tasks so that we can actually connect with our patients and do the right treatment for them, craft the right journey for them. And this is a recent work in Lancet where we showed that this dream of going out into the community for early detection is only possible if we have AI models working with ECG. You heard Dr. Desai talking about ECG models looking into detecting hypertrophic cardiomyopathy, looking into early signs of amyloidosis. And these models are already there. They're not only looking into the electronic health record, they can be implemented in community. You can have EKG wearables, data that is collected out there with signals that can be processed so that people can come in, and then you can have higher caliber referral to tertiary care centers like Cleveland Clinic so that patients are more precisely and timely treated. We have ideas about patients doing their imaging themselves. This is no longer a concept. It is true, with sonographer shortage, in the very near future, patients are going to come up with their own images scanned by themselves or their colleagues, and then they will also have their own ejection fractions already calculated. So you're not going to have the data done in the clinics. The data may be already coming to you, and then the sonographers and physicians are going to interact with that information and get a few more information. Patients will be exercising with patch and collecting the data. And with a large language model, then you will input all this information and you'll automatically get a report that is coming out so that you're tweaking. You're going to connect with the patient. You're going to be more with your higher domains of knowledge and not doing this mundane work of trying to generate reports, just correcting it. And this is all possible, and this is happening at the moment. It's currently happening. But it will also elevate you because it will show you that there is new knowledge with the use of lens of AI. We'll no longer have the battle where people in the guidelines committee are having sleepless nights. We'll have AI to rescue them. There will be no more fights because there will be models like this that will be more precise. They will work for all heterogeneous data. It will avoid our clinical trials from failing. For example, the TopCat trial, when we tried this diastolic dysfunction model, it was able to work out and show the benefit of spironolactone in that failed trial. So that's the promise. It will work not only for looking out for diastolic dysfunction, and this is the latest work a few months back we published, where we showed that diastolic dysfunction model, when visited in patients with aortic sclerosis, it was able to extract the milieu and tell which patient of aortic sclerosis will develop aortic stenosis. And not only the model was able to predict in databases, but we showed that it was able to, in sodium fluoride scanning, show the inflammation. So there is a new knowledge. Maybe the milieu of the disease is not in the valve. It's systemic, and it can be extracted using this knowledge. And this is not just my work. This is the latest work also from Rohan Kera's group, where look at where the EKG model looks. It looks in diastole for prediction of aortic stenosis. And here, in patients with aortic sclerosis who developed aortic stenosis, the model was looking at the left atrium. So there's a lot to explore, understanding even valvular heart disease, how do they develop? So new knowledge, new direction, new lenses. We need to be prepared for that. We can extract tissue-level information from ultrasound images and develop and provide MRI-level information from handheld ultrasound, and this is work that we published in JACC. This is a near future that is possible. So moving on from just simple extraction of data to creating data, generating echocardiography from ECG, creating the digital twin. And you can imagine where the field is moving. You're going into prediction, you're developing instead of cutting the patient open and starting the patient on therapy, you treat first the twin and see if there is a success and present that to the patient. Everywhere in the architects industry, when we develop a home, you have a model of how the home is going to look. Why don't we do that for us? So we will elevate ourselves to become therapy planners and designers and not just be diagnosing patients and just be in our mundane world. And we do not have the luxury of making 230 million years of mistakes and random variation to produce the intelligence of the human brain. But we can certainly preserve the intelligence of a human brain, not replace it, and relegate AI to the low-caliber activities and augment our critical thinking, which is going away. We need to bring the human back, and that's only possible if activities that we do not like, let it be given to AI, and create better systems, more powerful thinking, and more powerful technologies. And I know Dr. Rodriguez is going to tell you all about the limitations. And we have all the limitations in this Lancet Digital Health paper, but we do not have a chance to miss it out. We need to work with all these limitations, understand the limitations of the AI, and augment our own existence as humans. AI is the new beginning of the art of echocardiography. Augmented intelligence will make new generation of echocardiographers and sonographers. Thank you very much.